Welcome to Sex Plus Health Podcast. I'm Fred Wyatt with the American Sexual Health Association, ASHA. Today, we'll be talking about some pretty exciting new developments in contraception. And, new options are really important. There are about 61 million women of reproductive age in the United States. And given that the average desired family size is 2 children, that means women often must use some type of birth control for 3 decades. And there's no one-size-fits-all approach. Needs vary by an individual, and those needs really change a lot over the course of a lifetime. We're fortunate. We've got a lot of options available. Each one comes with advantages and disadvantages. And our guest today who's going to help us navigate all this is Dr. Noor Dasouki Abu-Alnadi, known by her patients and staff at UNC Chapel Hill as Dr. Noor. She is an expert minimally invasive surgeon. She treats the full scope of gynecologic, surgical, and pelvic pain issues. She's also our dear friend and a scientific advisor. Dr. Noor, thank you for taking time to talk with us today.
Thank you, Fred. I'm super excited to be here. This is not my first time on your podcast, so I feel very honored to be able to be welcomed back.
Well, we're thrilled to have you. So I want to start by discussing some new innovations in contraception and, who might benefit from these new options. We've got 3 of them really on our radar. A new low-dose contraceptive patch, Torla, a new annual contraceptive ring, Anavera, and a hormone-free contraceptive gel called Phexxi. So let's start with Torla. So it is a contraceptive patch, and while there is an existing contraceptive patch option, Torla is a new low-dose option. The patch is used in a 4-week cycle. Each patch is applied and worn for 7 days, so 3 patches are used every 3 weeks. When the 3rd one is removed, a patch-free 4th week begins before the 4-week cycle repeats. So it's a low-dose option. How much of an advantage is that?
Yeah, so I think the first thing is kind of taking a step back and understanding what is inside of the patch itself. So it's an adhesive. It technically only comes in one beige neutral color that you would apply onto a certain area of your body. So it could be the upper arm, the back, the butt, along the abdomen. And what it does is that it continuously releases hormone, and it's 2 hormones. It releases a progesterone and an estrogen. The progesterone essentially thickens the cervical mucus and it prevents sperm from going through the vagina into the uterus. And then the estrogen is really there to be able to suppress ovulation so you don't produce an egg. So it really works in 2 different ways. The benefit of the Torla compared to prior forms of the patch, which some people will remember the Xulane patch or the Ortho Evra patch, is that the lower dose of that estrogen actually results in a lower risk of venous thromboembolic events, which means blood clots. So whether that's a stroke or a blood clot in the leg or a blood clot in the lungs. And that's because studies have shown that the patch itself actually has a higher serum concentration of estrogen compared to even high-dose birth control pills. And so the Torla is really meant to be an alternative to see if you can have an equivalent form of birth control, but not necessarily have the same risk. And it does accomplish that, which is great.
It sounds like it. That sounds like a pretty big advantage. Is this something that you talk about, kind of frequently with your patients? How often does this come up?
Yeah, I usually kind of take a couple things into consideration before I offer things like the patch. I always ask patients, what is the frequency in which you want to take your birth control? And then the other thing is I always have in my mind a list of contraindications or reasons why as a medical provider, I wouldn't give a patient the patch. And the big one that you have to remember for Torla, whether you're a patient who's asking for it or a provider who's prescribing it, is that if you carry extra weight, so if your BMI is greater than 30, so 30 or more, then it's actually not as effective. And so talking about other forms of birth control is recommended, not just through the FDA labeling, but practicing OBGYNs, family physicians, individuals who are giving contraception would all agree that it's not the best form of birth control specifically for that patient population. There are some other medical contraindications, but if you're young, you're healthy, and that BMI cutoff does not apply to you, then it's actually a really easy form of birth control to take that is very low. It's not like very dependent upon the user. It's very user friendly. So I think from that regards, it's a great option.
It sounds like it's a pretty convenient option. It's easy to apply, and of course that's a big piece of adherence is just making it easy to use. You talked a bit about who might not be a good candidate. Is there any patient in particular who might be a really good candidate for this? Maybe somebody for whom other birth control hasn't worked so well, or what would you say?
Yeah, I would say someone who is young, someone who is a very busy individual and wants like convenience of their birth control. Also, someone who doesn't tolerate oral medication very well. This is a great alternative. We have patients who have pill phobias. We have patients who also just get nausea with the estrogen component of birth control pills. I would say that overall, it doesn't have many medical contraindications. And I apologize, you're going to hear the train passing by my house because I live in downtown Durham and right by the tracks. But
Local ambient sounds, that's fine.
yeah, what can I say? We've all gotten used to it. Every
Right.
time I Zoom, every time I have a phone conversation, I always pause. I'm like, that's a train. But I think that you would be surprised to realize that most people are actually a really great fit for the patch. Some people, maybe on a more personal note, would not be comfortable with the patch because of the fact that it only comes in one color, specifically the twirla. So that's just something to remember. But there are so many different areas of the body in which it could be placed on. If you do have a skin sensitivity or you have a skin disorder that's exfoliative, meaning that you have a lot of sloughing of the skin, it's not a great option for you. So that is something that I think sometimes people forget. They may not tell their OBGYN or their family physician or their or any other physician who's prescribing them contraception, but not thinking necessarily about another medical condition they may have. So just remembering to advocate for yourself in that regards. But there really aren't many people who aren't a good candidate for it.
Oh, that's good to hear. The more options, the better, especially if they're convenient and they work well. So very good. Well, let me ask you about another one called Anavera. This is a contraceptive ring. And before I really get into it, let me just ask you first to explain, what is a contraceptive ring?
That is such a great question. I think it can be kind of a little bit misleading, or it can be a little vague, but it really is a ring. So I think of it in terms of like almost the same diameter as a hair tie in terms of the width and the actual diameter of this ring. So it's definitely very thin, it's very pliable, and it's made out of latex-free material. The point of it is that it's impregnated with hormones. So it also has estrogen and it has progesterone, and it slowly releases hormone where it reaches kind of like peak amount of release within about a week. The great thing about it is that it's so easy to put in, and women do not feel it. I prescribe it so commonly to patients because as much as the patch sounds like it's really great, you have to remember on the same day every week to switch it out. But when you use a contraceptive ring, you keep it in place. And so things like the NuvaRing, where you take it out for 3 weeks, or I'm sorry, you keep it in for 3 weeks and take it out for a week, or the Anavera, where you actually can continue to recycle it within that time frame, are just very user friendly. And I think having only 1 month at a time, having to switch it out makes it very easy. People also kind of forget that you can use all of these forms of birth control continuously, meaning in a non-cyclic manner. So you don't have to have a period every month. Everyone kind of freaks out when I first say that to them, especially my younger patients. They're like, that just can't be healthy. And some of my older patients who are a little bit more conventional, and I totally understand, but it's okay to not have a period every month. And you should consider that a gift from these medications. And so you actually can keep the Anavera in for the full 13 months that it's good for. You can do that also with the NuvaRing. The one distinction I like to remind people in terms of the actual ring itself is that the Anavera is a little bit bigger. So it's not enough that you're going to feel it, but it is a little bit bigger. And there's some other things in terms of, storage as well as sex that people kind of have to remember in terms of using it compared to the NuvaRing that are advantages. And we can talk more about that too.
Yeah, let me ask you about that. So does Anavera have to be removed before having sex?
No.
Can it stay in place?
Yeah, it can totally stay in place. I think the studies usually quote only 20 to 30% of patients can even feel it in terms of like when they're engaging in sex with their partners. So you don't have to remove it. So the aloe vera, the nice thing about it is that if you take it out of your body, you have a 48-hour window before you have to put it back in. That's very different than the NuvaRing where you only have 3 hours. So if you miss that 3 hour window, then you have to use backup birth control for 7 days. The 13-month ring or the aloe vera is one where you actually get a total of 48 hours, which I think makes it a lot easier. And the other thing is that the aloe vera is stored at just room temperature. And when you buy it, it actually comes with a very nice case in which you can store it. So when you take it out, you just wash it, and then you can put it in the case. And then if you decide to put it back in within a couple hours, you're welcome to do that.
So, so I latched onto something you mentioned there that it basically can give protection for a year. It sounds
Yeah.
like the aloe vera can. So my next question was going to be, so what are some of the advantages here? What sounds like that would be a big advantage in terms of
Oh,
convenience?
it's such an advantage. I mean, I think one, there's this idea again that you have to have a period every month that scares people. But once people go period free, they feel like their life has changed in regards to not having pain with their periods or not having heavy periods or noticing like persistent improvement in their skin symptoms, such as like acne that may be hormonally related. But it's just super easy to use. And I think one of the things that we tend to forget is like our lives are busy. And one of the many things we don't want to have to worry about is whether we're subjecting ourselves to potentially unintended pregnancy, even though we may be trying to use something. Every hormonal contraception and non-hormonal contraception, the unintended pregnancy rate is given as two numbers. There's a typical number, and then there is a perfect situation number. And most of us don't achieve perfect situation because life gets in the way. And so you just kind of have to remember, if you want something that's more long term, you want something that's easy. I think this is a great option because that perfect number is not taking into consideration not just user error but life in general, that gets us a little off track.
Yeah, so I see a trend here about convenience, and we talked about that with Twirl, and that's such a big thing. I mean, I have daily eye drops, and I miss those half the time. It is eye drops, so I can imagine, right?
And yeah, so I remember being a medical resident. I was an OBGYN resident. I started birth control. I was taking birth control pills. Pills are great, don't get me wrong, but I was so inconsistent with taking them because my schedule was just so unpredictable. Sometimes I get home at 7, sometimes I would be on call, sometimes I would like travel to a different hospital, so I wouldn't have my pack of pills. So I would joke around that it was like popping estrogen left and right because I'd go one day with it, 3 days without it.
Mm.
The nice thing about all of these medications is that they're very easy to use. You can set reminders for yourself. So the aloe vera actually comes with an app. So that way, if you download it, it can remind you when to take it out, when to put it in. I think the other thing that people kind of have to remember is that even though these are technically longer term usage, meaning you can use them for up to a year, you can use them for up to a month, their ability for you to be able to easily stop them or take them out and try to get pregnant is just a couple of months. So it's usually no more than 6 months will it take for your regular ovulation to come back and for you to attempt pregnancy. And that's on like the higher end of normal. Most patients, it's 2 to 3 months, but you can start trying to get pregnant after or immediately after stopping the medications.
Okay, and you also mentioned NuvaRing. So one distinction between the two rings is, as I understand it, aloe vera can prevent ovulation for about 13 cycles, whereas NuvaRing provides protection for a month. Is that?
Yeah, that's correct. So you have to keep switching it out every month. The other thing is that when you get your prescription for the NuvaRing, it comes with an ice pack because it has to be refrigerated. So you better get home and you better put it in the refrigerator. And you have to, you got to think about it like if you're in the middle of a vacation and you didn't bring your NuvaRing and you didn't figure out a way to store it, then you're kind of in a bind. And the ring can be technically kept into place for a minimum of 3 weeks and up to 5. So it's not like the hard and fast is not a month. So it's for, you can suppress ovulation for 3 weeks, or you can keep it in for as long as 5, and it has equivalent efficacy. So it's just as good either way.
Okay. Is there anyone who may not be a good candidate to use aloe vera?
Yeah, I tell patients who have pelvic pain or who have symptoms of like vaginal infections, or if they have any concerns of like vaginitis, I would recommend for them not to use it. There are some reports in about 10% of patients that they'll have some irritation, that they may notice a difference in their vaginal discharge, and that can be bothersome to some patients. Some patients also just have a fear of placing it themselves. Everyone should know that nothing gets lost in the vagina, meaning you can totally pull it out yourself. But if you have a younger patient who may not be as well versed with their body, then maybe that's a patient who is not going to feel comfortable putting in, and is probably equally not going to be as comfortable with taking it out. So those are people where I say maybe it's not as user friendly in that situation.
All right. The last one I wanted to ask you about is Phexxi, and this is a little different. It's a hormone-free contraceptive gel that's inserted into the vagina right before penis and vagina sex. It works by keeping the vaginal pH within the vagina's normal pre-sex range, counteracting the influence of the semen and incapacitating the sperm. So I'm going to ask you to help us unpack that, the mechanism of action. I mean, what is the vaginal pH balance, and how does keeping it stable work as contraception?
Yeah, I think a lot of people, when they hear about Phexxi, they're like, oh my God, it's a spermicide, and spermicides are like no good. So part of that statement is true, in the sense that spermicides are really not that effective in terms of preventing pregnancy. They're only 70% effective. But Phexxi is a gel, and the whole purpose is that it keeps your vagina really acidic, and that counteracts this very alkaline semen, which has sperm. And so then it prevents sperm from moving around. So sperm are very motile, of course. That's how they get to where they need to be to result in pregnancy. And so it just essentially prevents them from moving around. And then as a result, then sperm and egg don't meet, and there's no formation of an embryo.
So who might be a good candidate to use this gel?
I think that Phexxi works in a variety of cases. So I think it works in patients who are already using another form of birth control and are looking for something that is non-hormonal, or they are on something that's hormonal and they just want to add that extra layer of protection. So Phexxi is one of the few forms of birth control that is compatible with things like a pill. It's compatible if you're on the patch. It's compatible if you're using condoms. It's compatible if you're using a diaphragm. So I would say, if you're using something especially that's not on the higher end of preventing pregnancy, like condoms or a diaphragm, adding Phexxi actually improves your ability to prevent pregnancy. I think that Phexxi is also really great for individuals who may not be able to take hormones because of medical conditions. I think that Phexxi also has this ability to be used as a lubricant. So if you're someone who wants the added protection, but you also normally use a lubricant with your partner, then this can serve both purposes. So it has a lot of advantages.
Um, so I mentioned earlier that I've noticed a trend that a lot of these things really seem to be designed to be convenient and easy to use.
Yeah.
I'm just curious, just what are some other innovations in contraception that you think we might can see in the coming years? What's cooking in the pipeline?
Yeah, I think probably the big one that we're all really excited for is when they come up either with a ring or they come up with a patch that's progesterone only. And that's because of the fact that most medications that are hormonal birth control have both hormones, estrogen and progesterone. And estrogen gets a bad rep, and I mean, appropriately so, because it does increase your risk of having blood clots, which is probably one of the most serious complications of using birth control. But a lot of patients um, who need hormonal birth control aren't candidates for estrogen because of their medical issues. And really, their only other option other than the pill is an IUD, but not everyone wants something that's as long term. So I think alternatives that could be easier to comply with, easier to use, such as like the ring or as the patch, would be a great thing for us as providers, but I also think just to give patients options.
Mm. So I want to ask how you help patients sort through all this to actually choose an option. When I was doing a little bit of prep ahead of our conversation, I was looking at our birth control contraception comparison chart. And
Yeah,
that thing has gotten so big, I'm like, my gosh, it's just
I
option
know.
after option, which is really great, but it can be
Yeah.
confusing and a little bit almost overwhelming. So how do you talk with people and help them sort of winnow down what might be a good choice?
Yeah. So the first thing I ask everyone is, how soon do you think, if at all, you want to get pregnant? And if they're like, I don't want to get pregnant at all, or I'm just looking for birth control like for the next year, then that can kind of give me an idea in terms of, do they want something that's more long term, something that lasts 3, 5, 7 years, or do they 10 years, or do we think that maybe they just want something for the next 6 months before they try to get pregnant? So reversibility. So there's that part. The other part is medical, medical problems, right? Because every person has potential reasons why it may be unsafe for them to take a certain kind of birth control or use a kind of birth control. And the other thing is, I asked them about their lifestyle. I'm like, what sounds easy to you? Are you a person who wants to take a pill every day? Or are you a person who really just wants to be hands-free and feel reassured that you will not have to do very much in terms of management of your birth control? And then based on that, I'll start counseling them using a couple of different resources that they themselves, after the visit, can always look through and are very accessible. They also have like some great charts. So I usually use bedsider.org, which is a great organization that has a lot of tabs just to explain each of the different types of birth control, but also has very easy charts that a lot of organizations or a lot of hospitals supply to patients. The other one is actually Planned Parenthood. I think, a lot of people think Planned Parenthood is there for abortive services, but it's actually there for obstetric and gynecologic services for a large portion of women. And their website is so easy to use. You just hit the Learn More tab, and then you go to birth control, contraception, and then everything is listed there. And it's so great because it's also organized based on commonly asked questions. So I think if a patient isn't quite sure what they want, those are the two resources I'll point them to. And I always ask those preliminary questions too, as well, just to get kind of a baseline of what they're looking for.
Good, and we'll include those resources in the show notes. So that's good. Thank you for mentioning that.
Yeah.
Let me ask in the few minutes we have left. When patients come to you and they're like, this option isn't working for me, I want to try something else. What is it that usually provokes them to want to try a new method of birth control?
Yeah. So trying a new method of birth control, I mean, there are a variety of reasons why people will ask. Sometimes it's because they got pregnant on that same birth control and they're like, I can't do this again.
There you go.
Sometimes it's because they have side effects such as like unscheduled bleeding, or they have really considerable nausea or breast tenderness. And that can be as a result of the balance of the different hormones within their medication that they're taking. Sometimes patients will want to get on something that is less work for them because they're just noticing that having to take something every day or keeping track of something is a little bit more difficult. And other reasons are because they're looking to get pregnant in the near future, and so they're switching it out. I think the last thing may be price, but I think nowadays, because there are so many different alternatives in terms of getting coverage for things such as IUDs, Nexplanons, even, pills themselves. I mean, there's a lot of different alternatives that patients should know about to be able to advocate for themselves for medication. So you can always ask your provider to look at the $4 list on Walmart, because all those birth control pills are going to be a lot cheaper. And let me tell you, it doesn't matter if you get the $100 one or the $4 one, they're all the same. If you're looking to get an IUD and your provider is quoting you $1,500, actually call your local Planned Parenthood, because based on your salary or your income, there can be a pay scale that is reflective of what your annual income is. And there are payment plans that are much more reasonable than a lot of private institutions or even public institutions. And then there are certain grants that are provided to certain public institutions that will actually give patients long-term birth control for free. So there are a lot of different avenues I think we don't discuss enough when it comes to the price. But I have had more than one patient just very openly tell me, like, I can't afford this kind of birth control, so I need another alternative. So I think that's also been something that we've had to learn to maneuver around.
All right. You mentioned condoms a couple of times, and that just sort of triggered in me that I should probably ask you about that, because while we've been talking about some really fantastic ways to prevent pregnancy, condoms are still what you look to prevent sexually transmitted infections. And so do you have conversations about, I guess, dual use with your patients a lot?
Yeah, so I do ask patients, how many sexual partners they have, so if they're in a monogamous relationship or not. I also do ask, are their sexual partners male, female, both, or neither, just to get a better understanding of what their general risks are. And I remind them that if they're not in a monogamous relationship, or if, they if they themselves at any point have any change in their feelings regarding things such as having sexual pain, or a change in the consistency or the look or the odor of their discharge, that they do definitely need to be checked out, and they should consider using condoms with their partner. Condoms are the only way to prevent sexually transmitted infections. The only thing that may slightly improve some infections, and this is not scientifically substantive, is actually using Phexxi, just because it alters the vaginal flora, but it really only reduces the risk of bacterial vaginosis, and that scientific data it's not strong. Using spermicides actually irritates the vagina, and so then that increases the risk for some infections such as HIV. So that would be a medication that I would say, hey, you definitely need to try to use condoms with it.
Good point.
So those are just like the nuances, but in general, of course, barrier contraception or condom use is highly recommended, especially if you think that you would be at risk for contracting a sexually transmitted infection from your one partner or numerous partners.
I wish all doctors were like you. Dr. Noor, thank you so much. You're absolutely the best. I know this is like twice we've had you on the podcast. I got to tell you, I can feel an episode 3 coming up at some point. I hope that's okay.
I'm totally fine with that. I love this.
There we go.
And
I should have mentioned in the beginning when I was introducing you, you're also on our board of directors, which means you're kind of my boss. So there you go.
Oh my gosh, no. I think that you carry more power here. If it hadn't been for you, I like really, really appreciate having this conversation, and you've clearly kept this podcast alive and well. So all of the kudos goes to you.
Thank you so much. Well, we really appreciate this. Thank you, everybody, for tuning in and listening. You can listen to our other podcast with Dr. Noor on our ASHA podcast page, and we'll link to that in the show notes as well. Please check in with us often. We'll have a lot of updates, and you can also find us on social media at InfoASHA. So until next time, thanks a lot. This is Fredo. Take care, everybody.